Okay. Hello everyone, my name is Victoria Stewart, and today I will be doing a research review on the article titled The Impact of Early Intervention on Speech and Lexical Development for Toddlers with Cleft Palate, a retrospective look. And this article is by Mary Hardin Jones and Kathy L. Chapman. It was published in 2008. January 2008, and this is a retrospective study that was conducted to examine the impact of early intervention on speech and lexical development for toddlers with cleft palate. So first we're going to talk about the review of literature on early intervention that the article discusses in the beginning. Basically, infants and toddlers with cleft palate are frequently enrolled in early intervention programs because of their increased risk of delays in speech and lexical development, yet there's not much data and research showing the effectiveness of these programs or even any data for this age of children with cleft palate. It's very limited. The majority of the data out there is for older preschool and school-age children, and generally the research we do have has shown that articulation therapy is effective in reducing speech sound errors, and that the therapy time is significantly reduced for children who exhibit glottal or pharyngeal errors when a phonological approach is used. And we also know that having parents involved in the therapy session seems to improve language development. So typically early intervention for children with delays in speech sound development and expressive language, they focus on the expansion of the child's lexicon. That's what the article talks about a little bit. The idea is that early phonological delays in children with cleft palate are related to language development. So traditional therapy focus has usually been to improve the child's expressive vocabulary, which in turn should naturally lead to the resolution of phonological issues. These intervention strategies are used because so many toddlers with cleft palate demonstrate delays in speech sound development that appear to be associated with delays in expressive language. It's unclear whether this therapy approach is effective in expanding their consonant inventory versus just doing it in a way that it focuses on consonant inventory expansion. Scherer, in her research, noted that intervention that's designed to enhance general language development typically results in improvement of the child's sound inventory. So she does back that up. Another approach that's sometimes used for early intervention is a naturalistic approach carried out by either parents or SLPs, and it's been effective in expanding vocabulary and phonetic inventories for toddlers and older children with cleft palate. And although both approaches appear effective, it's not clear which one yields better results. We just know that they both work. With that in mind, this retrospective study was conducted to examine the impact of early intervention on speech and lexical development for toddlers with cleft palate. Okay, so now we're going to talk about the method of this study. The method included obtaining speech samples from 10 27-month-old toddlers with cleft palate who had been referred for therapy at 17 months of age. And these toddlers were compared to 10 toddlers with cleft palate who had been referred but who did not receive speech therapy. So both groups were compared to two other groups of children who had never been referred for therapy. And the participants of the study included 40 toddlers, and 30 of those had a repaired cleft palate and 10 without a repaired cleft palate, did not have their cleft palate repaired. So the children were all 27 months of age, and they included 33 males and 7 females. All the children in the study demonstrated normal receptive language functioning, and I believe that the article talked about that was measured by using the PLS, and they were all within normal limits. The age of onset for therapy for the toddlers had an average range from 9 to 21 months. And because this was a retrospective study, experience and proficiency of the therapists were not controlled, and there was no experimental control for the intervention. The SLPs pretty much decided the treatment goals for each child, and they reported their progress via progress reports to the researchers. So researchers really didn't have any control over what was going on in the therapy room. So the procedure of the study involved using audio and video recordings while the children interacted with their primary caregivers in their homes, and these were done at both 17 and 27 months of age, when the child respectively was 17 or 27 months. In addition, the parents were asked to complete the MacArthur Communicative Developmental Inventories at each session. The recordings of these sessions were transcribed by the study authors using IPA, or the International Phonetic Alphabet, and this gave the researchers information regarding the size of the child's consonant inventory, as well as being able to look at the place and manner of their articulation preferences. A multivariate analysis of variants, commonly called MANOVA, was performed so we could determine if significant differences in the speech production were evident among the 4 groups of children. So now moving on to the results. The results were really interesting and showed that the group of children with cleft palate who were not referred for therapy actually continued to demonstrate speech production and performance similar to that of those of the non-cleft group. The only significant difference they found between the therapy and no therapy groups was that the percentage of glides that were being correctly used. Children who received therapy did produce more glides than the children who did not receive therapy. And I was really surprised when I read through the results, because I automatically assumed that those who received therapy would have been way more advanced than those who didn't, but it wasn't the case in this study. Both the authors did, during the discussion portion of the article, tell us that the prediction of language outcomes in young children with cleft palate is often very difficult to determine, and a primary problem that SLPs encounter is deciding who needs services and who will be fine without them. And we know from past research that the presence of stop consonants following surgery is a very strong predictor of later success for children with cleft palate. Early intervention is typically recommended when those oral stops do not emerge within 2 to 3 months following palatal surgery. So the findings of the study really emphasize the need for additional research documenting the effectiveness of early intervention programs for children with cleft palate. Okay, so now that we've talked about the study a little bit, I'm going to talk about the pros and cons. Starting off with the pros, the study definitely showed the importance of early assessment, and it supports the argument for intervention that when those stop consonants do not emerge in a timely fashion, early intervention is probably warranted. The study also gives credibility to an early diagnosis, because the earlier you get those kids the therapy they need, the better off they will be. And even though some research reports that children are able to catch up following those palatal repair surgeries without therapy, the referring SLPs in this study were able to successfully identify the toddlers who needed that therapy, so they didn't have to wait for those future problems to pop up and then be dealt with later. The SLPs in the study were able to pinpoint who did need therapy and who didn't, which was really cool. This means that clinically, the presence or absence of those oral stop consonants is a key clinical finding that can assist SLPs in identifying children who need those early intervention services. Some of the cons of the study was retrospective, and it did lack an experimental control, which really limited the study and the findings and information that could have been gleaned from it. I honestly had to read through the results a few times because I thought that the research was going to reveal more than it did. But the article states that one major weakness of the study was the inability to control the SLP's experience and proficiency, or the amount of time each therapist devoted to each treatment goal. So I think that probably, if they would have had a study set up where they had some constants, like they had some specific treatment goals or something like that, they could have they would have been able to have more specific answers, I think, to some of these questions that they had originally set out to answer. But the fact that they couldn't control what the SLP was doing in the therapy room, they couldn't control how much time each goal was being targeted, and then some of the goals they did target were questionable. For example, a lot of therapists chose to use oral motor exercises, even though it is commonly criticized in our practice for being inappropriate, an inappropriate strategy. I think at one point in the article that it said that they didn't know in an hour session if 40 minutes was devoted to speech sound therapy or if it was devoted to oral motor exercise therapy. They didn't know. So if they would have controlled that a little bit better, I think it would have been a stronger research design. Overall, though, I thought that this was a really informative article, and I will definitely be using some of this information in my future practice. Before, I didn't understand the importance of the stop consonants emerging 2 to 3 months post-surgery, but now I definitely see how that would be a big clinical indicator of whether a child is a candidate for early intervention or not. I do think that the research design could have been stronger, as I said earlier, but overall I thought that the researchers were able to glean some useful information from the study. And early intervention is an area that I'm personally interested in, so this was a good one for me to read and review. So that was my summary of it. Here is the article. Yes, so thank you for listening.